All right, let's dive right in today. We're tackling angina, something you future doctors definitely need to be ready for in the MSRA, especially since it's so common here in the UK. So many people are affected by it.
You know, it's interesting because angina isn't just about memorizing symptoms for the exam. It's really about understanding the mechanisms, the why behind it all. And that actually helps connect it to the bigger picture of heart health.
Okay, so let's start with the basics. What exactly is angina?
Angina is basically the heart muscle crying out for help. It's like a pain or discomfort because the heart isn't getting enough of that lovely oxygen-rich blood.
And that's usually because of problems with the coronary arteries, right?
You got it usually narrowed or blocked arteries.
Yeah.
And, the sources actually use some pretty vivid descriptions for the pain.
Yeah, I saw that squeezing, pressure, heaviness, even a tight band around the chest.
Exactly. It's not exactly subtle.
But wouldn't other conditions cause chest pain too? How can doctors be sure it's angina and not something else?
That's where differential diagnosis comes in. You're right, chest pain can be a symptom of loads of things. It could be gastrointestinal or musculoskeletal, even anxiety can cause it.
So it's like a process of elimination.
In a way, yeah. You have to look at the whole picture, the patient's history, a physical exam, and of course, order the right investigations.
Speaking of investigations, the sources mention things like blood work ECGs, echocardiograms. What exactly are we looking for with each of those?
Hold on, before we jump into tests, I think we need to make sure we're clear on the different types of angina first.
Right, the sources mention stable versus unstable.
Okay, so stable angina, that's the most common one. It's usually triggered by exertion, things like physical activity or stress.
So like if someone's working out or maybe having a stressful day at work.
Exactly. It's kind of like the heart saying, hey, I need more oxygen. But then it calms down when you rest or take medication.
So stable angina, it's sort of predictable. It happens when you do certain things and then goes away when you stop.
Right. But then you have unstable angina, and that one is much less predictable and way more dangerous because it can happen even when you're resting or even sleeping.
Oh, wow. So if someone's just chilling on the couch and they get chest pain, that's a red flag.
Huge red flag. Unstable angina could mean there's a serious blockage in the coronary arteries, and that means the risk of a heart attack is much higher.
That sounds scary. So unstable angina is definitely a medical emergency.
Absolutely. No time to waste with that one.
Okay, so we got stable and unstable. Now, before we get to the tests, I'm curious, how common is angina actually here in the UK? Do we have any stats on that?
The sources do actually dive into UK-specific numbers, which is super useful for the MSRA. And get this, around 8% of men and 3% of women aged 55 to 64 have reported experiencing angina.
Wow, that's higher than I thought.
Yeah.
And I'm guessing those numbers go up as people get older.
You bet. And it's not just age, ethnicity comes into play too. South Asian populations in the UK, for instance, have a higher risk compared to the general population.
That's really important to keep in mind when you're seeing patients, right? You really have to consider individual risk factors.
Absolutely. Okay, so speaking of those risk factors, what are some of the usual suspects for angina?
Well, I know smoking, high blood pressure, high cholesterol, diabetes, those are all bad for the heart in general.
Those are the classics. And don't forget family history, a sedentary lifestyle. Those matter too. But what's really interesting is the role of socioeconomic factors.
Socioeconomic factors, you mean like income level, education, things like that can affect your risk of angina?
Exactly. Studies have shown a strong link between deprivation and heart problems, including angina. It's complicated, of course, but definitely something to be aware of in practice.
So angina isn't just a medical issue, it's connected to social factors too.
It really is, and that's why it's so important to think about the whole person. Not just their symptoms, but their life circumstances too.
This is fascinating. I can already see how this deep dive is going to be helpful beyond just the MSRA. This is important for any doctor working with patients in the UK.
It really is.
But let's get practical for a minute. How does angina actually show up in the clinic? What are the symptoms doctors should be looking out for?
That's a great question. Let's talk about the clinical presentation of angina. It's not always textbook,
So not everyone gets that classic crushing chest pain we see in the movies.
Sometimes it's more like a tightness or a pressure, even a burning sensation or indigestion. And the pain isn't always just in the chest. It can spread to the arms, neck, jaw, or back.
That sounds tricky.
Yeah.
So how do you tell the difference between angina pain and, say, heartburn or a pulled muscle?
It all comes down to taking a good history, asking the right questions about the pain, what triggers it, how long it lasts, what makes it better or worse.
And I'm guessing you also consider their risk factors and overall health.
Definitely. We're putting together a puzzle looking at the whole picture to figure out what's going on.
Makes sense. But I bet there are some tricky cases too, right? Like what about elderly patients? Do they always present with the classic symptoms?
Not necessarily. Older patients might not experience pain as intensely, or they might have other health issues that mask the usual symptoms.
I see. So angina can be a bit of a chameleon sometimes.
It can. And that's why it's so important to be aware of these variations, especially for the MSRA. They love to test your ability to think critically and apply your knowledge to different scenarios.
Okay, so we've covered the types of angina, the risk factors, how it presents in patients. What's next in the diagnostic process? How do we confirm a suspected case of angina?
Right, so we're suspecting angina based on what the patient's telling us and what we're seeing, but we need to back that up with some solid evidence.
Exactly. We need to confirm the diagnosis, and that's where investigations come in.
Okay, so the sources talk about blood tests, ECGs, echocardiograms. Can you break down what each of those tells us?
It's like we're gathering clues to understand what's happening with the heart. So with blood work, we're checking things like full blood count, renal function lipids.
So making sure the kidneys are doing okay, checking cholesterol levels, that kind of thing. Exactly. We want to rule out other potential problems and just get a baseline picture of the patient's overall health.
Okay, so blood work gives us the broad strokes. But what about those more heart-specific tests?
Right. So a 12-lead ECG, that's crucial. It gives us a real-time look at the heart's electrical activity. We can see if the heart muscle is struggling, not getting enough oxygen.
And that's called ischemia.
Right. You got it.
Yeah.
We're looking for specific changes on the ECG called ST segment changes, which can indicate ischemia.
Got it. And the sources also mention an echocardiogram. What's the point of that one?
An echo uses sound waves to create images of the heart, so we can actually see the structure and function. Is it pumping properly? Are there any leaky valves? Has there been any damage?
So ECG is electrical activity, and echo is the physical structure.
They kind of work together then.
They do. They give us a really good understanding of what's going on with the heart. And then for unstable angina, there's another tool we use called the GRACE score.
Oh, yeah, I've heard of the GRACE score, but to be honest, I'm a bit fuzzy on what it actually is. It's basically a risk calculator. It helps us figure out the likelihood of serious complications in patients with acute coronary syndrome, which includes unstable angina.
Complications like what exactly?
Things like a heart attack or even death.
Okay, so the GRACE score helps predict how risky the situation is.
Exactly. It takes into account things like age, heart rate, blood pressure, some blood test results, and the severity of their symptoms, all that stuff to give us a more precise risk assessment.
That sounds incredibly useful for making treatment decisions.
It is. So speaking of treatment, how do we actually help patients with angina?
Well, that probably depends on what kind of angina they have.
Right.
Stable versus unstable.
Absolutely. The management strategy is tailored to the individual patient, but the overall goal is always to reduce those pesky symptoms, improve their quality of life, and most importantly, prevent those serious complications we talked about.
So for stable angina, what's the typical first line of treatment?
It's a two-pronged approach: lifestyle modifications and medication. We always encourage patients to quit smoking if they smoke, eat a healthy diet, get regular exercise, and manage stress.
The good old healthy lifestyle advice.
It really makes a difference. And then on the medication side, we often start with beta blockers or calcium channel blockers.
Can you remind me how those work again?
Sure. So beta blockers, they work by slowing down the heart rate and reducing blood pressure, basically taking some of the workload off the heart. And calcium channel blockers, they relax and widen the blood vessels, which improves blood flow to the heart muscle.
So beta blockers calm the heart down and calcium channel blockers open up the pipes.
That's a great way to remember it. And the key is to find the right medication and the right dose for each patient, taking into account their other health conditions and any potential side effects.
Personalized medicine in action. The sources also mention other medications, like long-acting nitrates. Are those used instead of the GTN spray?
Not necessarily. Long-acting nitrates can be used along with other medications to provide more sustained relief from angina symptoms. GTN is more for immediate relief during an attack.
I see. And what about those secondary prevention medications like aspirin and statins?
Those are essential too. Aspirin helps prevent blood clots, which is crucial because patients with angina are at higher risk of having a heart attack. And statins, they lower cholesterol levels, which addresses the root cause of those blockages in the arteries.
So it's a multi-pronged approach. Manage the symptoms, prevent clots, and tackle the underlying problem.
Exactly. And all of this is in line with the latest NICE guidelines for managing angina here in the UK.
Speaking of NICE guidelines, they emphasize managing something called nitrate tolerance. What is that exactly?
Basically, nitrate tolerance happens when the body gets used to the effects of nitrates over time, so they become less effective at relieving angina symptoms.
So if someone's been using GTN spray regularly, it might start to lose its punch.
That's right. And that's why NICE recommends strategies to prevent or manage this tolerance. One way is to make sure there's a nitrate-free period each day, so the body can regain its sensitivity to the medication.
It's like giving the body a break from the nitrates so they work better when they're needed.
Exactly. And this can be done by using an asymmetrical dosing schedule or by using modified release nitrates.
Modified release nitrates, what are those?
They're formulated to release the medication gradually over a longer period, so it provides more consistent control of angina symptoms and avoids those peaks and troughs in medication levels that can contribute to tolerance.
So it's about maintaining a steady level of nitrates in the system.
Precisely. And the goal is to have a nitrate-free window of about 10 to 14 hours each day. This allows the body to reset and become more responsive to nitrates again.
Okay, that makes sense. So we've got lifestyle changes, medications, strategies to manage nitrate tolerance. But what about those more invasive procedures? When are those considered in the management of angina?
You're talking about revascularization procedures like PCI and CABG?
Yeah, PCI and CABG, those are the big guns, right?
They can be. These procedures are typically reserved for patients who have severe angina symptoms or whose angina doesn't respond well to medication.
So if lifestyle changes and meds aren't cutting it, then PCI or CABG might be the next step.
That's right. PCI stands for percutaneous coronary intervention, and it's also known as angioplasty. Basically, a catheter with a tiny balloon is inserted into the blocked artery, and then the balloon is inflated to widen the artery and improve blood flow. Sometimes a stent is also implanted to keep the artery open.
It's like a plumbing job for your heart.
Exactly. CABG, on the other hand, is a more invasive open heart surgery. It involves taking a healthy blood vessel from another part of the body and using it to create a bypass around the blocked artery.
So PCI is clearing the blockage and CAG is creating a detour.
You got it. And the choice between the two depends on the location and severity of the blockages, the patient's overall health, and other individual factors.
That's a lot to consider. But it sounds like there are effective options available, which is good to know.
Yeah.
What about the long-term outlook for patients with angina, though?
That brings us to prognosis and potential complications. And this is something the MSRA really wants you to understand, the potential consequences of angina and why effective management is so important.
Right, because angina isn't just about chest pain. It can be a warning sign of more serious problems down the road.
Exactly. So what are some of those potential complications we need to be aware of? Well, for starters, angina, particularly unstable angina, can significantly increase the risk of a myocardial infarction.
A heart attack.
Yep. That's a serious and potentially life-threatening event. And it makes sense considering angina is a sign that the heart isn't getting enough oxygen.
Right. And are there other complications we should be worried about besides a heart attack?
Oh, absolutely. Heart attacks aren't the only concern. Angina can also lead to things like heart failure, where the heart can't pump blood efficiently like it should, and arrhythmias, irregular heart rhythms. And in some cases, it can even lead to sudden cardiac arrest.
Wow. So potential consequences are pretty serious.
Yeah.
It really highlights why we need to catch angina early and manage it effectively.
Couldn't agree more. And that's something the MSRA really wants to see. Do you understand the potential risks and the importance of good management?
Makes sense.
Mm-hmm.
Okay, so let's shift gears a bit and talk about how all of this applies to the MSRA. How are they going to test our angina knowledge?
Well, the MSRA loves to give you those clinical scenarios, the ones that make you think critically. They don't just want you to spit back facts. They want to see if you can apply your knowledge to real-life situations.
So we might get a patient presentation and then have to work through the whole diagnostic process.
Exactly. Like imagine they give you a case, a 60-year-old man with chest pain when he exerts himself. You'd have to figure out what questions to ask him, what investigations to order, how to interpret the result.
And then come up with a management plan.
Right. And they might even throw in some curveballs like the patient has other medical conditions that could complicate things.
So it's all about showing them you can think like a doctor, not just memorize a textbook.
Exactly. And one of their favorite ways to test that is with those single best answer questions, the SBAs.
Oh yeah, the SBAs. Those can be tricky. Can you give us an example of an angina-related SBA?
Sure. Let's say you have a 55-year-old woman who comes into your GP practice complaining of chest pain. She describes it as a tight band across her chest that radiates to her left arm. The pain comes unpredictably when she walks uphill, and it's relieved by rest and her GTN spray. She has a history of hypertension, and her mother had a heart attack at 62. The question is, which of the following investigations is most likely to be diagnostic in this case?
Hey, let me think about this. She's got those classic angina symptoms, the risk factors, the family history. So we need a test that can tell us for sure if there's reduced blood flow to her heart when she's active.
You're on the right track. Remember what we said earlier, which investigation can actually show us if the heart muscle is getting enough oxygen in real time?
I think I've got it. Would it be an exercise stress ECG?
Bingo! An exercise stress ECG would show us if there are any ST segment changes during physical activity, which would indicate ischemia.
So we'd have her walk on a treadmill or ride a stationary bike while we monitor her heart.
Exactly, you nailed it. That's the kind of clinical reasoning the MSRA is looking for. You considered everything, her history, symptoms, risk factors, and then chose the investigation that would give you the most relevant information.
That makes a lot of sense. This has been super helpful. I feel much more prepared to tackle those angina questions on the MSRA.
I'm glad to hear it. But before we wrap up, I want to go back to something we touched on earlier, the impact of angina on a patient's quality of life. It's not just about the physical symptoms, is it?
Right. Angina can really affect someone's mental and emotional well-being, too.
Absolutely. You know, the fear of having another attack, the limitations on their daily activities, the uncertainty about the future, all of that can take a toll.
So we need to address those aspects as well, not just focus on the medical side of things.
For sure. We need to provide reassurance, education, and support. Encourage them to join a cardiac rehabilitation program where they can learn about healthy lifestyle choices, exercise safely, and connect with other people who understand what they're going through.
So it's really about treating the whole person, not just the disease.
That's what it's all about.
Right.
And that's what makes a good doctor great. You know, when you take that holistic approach, you can truly make a difference in your patients' lives.
Couldn't agree more. Well, I think we've covered a lot of ground today, everything from the basics of angina to the latest UK guidelines, and even some MSRA tips to help you ace those exams.
Yeah.
Any final thoughts for our listeners?
Just remember, angina is a complex condition with serious potential complications. It's so important to understand the different ways it can present, the tests we need to diagnose it, and the treatment options available. And remember, effective management is about more than just medication. It's about supporting the patient's overall well-being and giving them the tools to take control of their health.
Excellent advice. And if you want even more resources and practice questions to help you prepare for the MSRA, don't forget to check out passthemsra.com. It's a fantastic resource for anyone getting ready for this exam.
It's a great resource. Best of luck with your studies.
Thanks for joining us today. And to all you future doctors out there, remember your journey doesn't end with the MSRA. It's just the beginning. Keep learning, keep striving, and never lose sight of the incredible impact you can have on your patients' lives.